All right. Well, again, welcome to our Women in Global Health Georgia chapter event on addressing gender-based violence during the COVID-19 pandemic, emerging risks and solutions. We are so glad to have you joining us today. And happy International Women's Day from yesterday. We are excited to be continuing the celebrations and the deep thinking about gender and global health with you today. If you are not already following us on Twitter, our Twitter handle that is newly minted is WGH Georgia USA. So please follow us. We'll follow you back. And also, I would like to invite you to introduce yourself in the chat box. Make sure that you click the option to all attendees rather than to just the panelists. That way you can see who all is here and what organizations we're representing today. And then following that, if you have questions for our speakers today, please enter those into the Q&A box. So with those kind of housekeeping items and words of welcome, we'll get started. I'm going to hand over to my co-chair here at Women in Global Health Georgia. I realize I did not introduce myself. Apologies, I'm Rachel Hall-Clifford, based at Emory University and co-chairing with the wonderful Mahal Waldastatic, and I'll hand it over to her.
Thank you, Rachel. Good afternoon, everyone, and thank you for joining us for this special webinar in commemoration of this year's International Women's Day. Like Rachel mentioned, my name is Mahal Waldastatic, and along with her, I co-chair Women in Global Health Georgia chapter, which was launched 2 months ago. Today's event is focused on exploring how the COVID-19 pandemic has exacerbated different forms of gender-based violence, including domestic violence in the United States, with a specific focus on Georgia. We'll be examining lessons learned around the best approaches to delivering survivor-centered prevention and response strategies. And to discuss this very important issue, I'm honored to be joined by Ms. Barbara Gibson and Dr. Catherine Yant, who will be hopefully join us shortly. Ms. Gibson is the Safe House Director at the Women's Resource Center to End Domestic Violence in Decatur, Georgia. She has been providing advocacy for survivors of abuse and trauma since she joined the Women's Resource Center over 30 years ago. Prior to her current role, she served as the organization's family advocate and conducted home visits to provide individualized support to survivors in the community. As Safe House Director, Ms. Gibson oversees the operations of the Safe House and provides emotional support, goal alignment, and transition services to its residents. In addition, Ms. Gibson develops and facilitates trainings on domestic violence, resilience, and self-compassion locally and nationally. She's also a registered yoga instructor and meditation guide. Barbara, thank you for being here today. And thank you, Dr. Yant, for joining us.
Hello, everyone. I'm so sorry that the Zoom link wasn't working.
No worries. It's perfect timing. I was just about to introduce you.
Wonderful.
Dr. Yant is Asa Griggs Candler Chair of Global Health and Professor of Global Health and Sociology at Emory University. She's also founding director of GROW, an initiative to advance scholarship, leadership, and social change with respect to women's and girls' empowerment, the prevention of gender-based violence, and women's health. Dr. Yant's research centers on the social determinants of women's health and is focused on understanding how social norms and empowerment-based programs can reduce gender-based violence and health disparities in underserved populations. She has studied gender-based violence and women's empowerment initiatives in underserved communities in Atlanta, as well as communities in Asia, Latin America, and the Middle East. Thank you, Dr. Yant, for joining us. It's a pleasure to have you both on this panel this afternoon.
Thank you
again. Since the COVID-19 pandemic started over a year ago, we have seen the gendered effects that it's had on women, including on their safety. And even before the lockdowns began, there was ample evidence that homes were not safe places for the many women and girls who experienced violence at the hands of their intimate partners or family members. Dr. Yant, I'll start with you. Have you seen evidence of this in your work, both at the local and national level, since the pandemic started? And if yes, what are some of the major trends that you have observed?
Thank you so much, Mahal, and the Georgia chapter for Women Leaders in Global Health. And Barbara, it's so wonderful to see you today. I wondered if I could just share a couple of slides, Mahal. Is that all right? And then I'll pass the baton. So the bottom line is that I think the evidence is mounting to suggest that the pandemic has had a substantial impact on a range of forms of violence in the family. And just to provide a very quick overview, which hopefully will set the stage for some of Barbara's commentary. There we go. Can everyone see?
Yes, we can see the screen.
Great. Okay. So just very briefly, our team, in collaboration with Nadine Kaslow, who also has worked closely with the Resource Center in the past, and two students have conducted a review, actually, of newspaper articles that focused on changes in various forms of domestic violence and in Child Protective Services reports. One of the reasons we relied on newspaper articles is because of the delay in getting detailed evidence on a national scale with respect to changes in these forms of violence under COVID and risk mitigation strategies. And of the 68 articles, newspaper articles that we identified, there are some pretty striking findings. First of all, you can see the distribution of these articles, with many coming out in April, about a month after the lockdown, citing a range of sources of data, including hospital records, police reports, court cases, hotline and emergency calls, CPS reports, police reports, court cases, etc. Many of these articles of reasonably good quality. The really striking findings are that a majority, irregardless of the data source, irregardless of the quality assessment of the newspaper articles, the vast majority of these sources are citing increases in rates of family violence, and very critically, decreases in Child Protective Service contexts. And what we think may be going on are the adverse impacts on women of stay-at-home orders and the adverse impacts of school closures and other services available to children on the ability to report cases of potential child maltreatment to Child Protective Services. And the pattern is very tightly aligned with the intensity of the lockdowns, where we see changes in Child Protective Service reports going down substantially in April, even more intensively in May, and the opposite trend with the average change in domestic violence rates by month peaking in May during the most intensive lockdown periods, and this is by week. So now our team is actually looking at the direct relationships between these contrary changes in reporting for domestic violence and Child Protective Service reports with specific risk mitigation strategies.
Thank you very much, Dr. Yant, for that presentation. Barbara, I'd like to bring you in and ask if the Women's Center has experienced a higher increase in demand for services in the past year, and what are some of the issues that you've observed in the last year that have been different from prior years?
Sure, thanks, Millette, and thanks, Dr. Yant. That was really helpful, the diagrams that you shared. I'm so glad to be here and talk a little bit about the work that we're doing at the Women's Resource Center and the things that we've seen. So to be clear, at the beginning of the pandemic, we experienced a drop in calls to crisis lines. And what we attributed that to was the ability of survivors to be able to get to telephones because they were sheltering in place. What we did also recognize, though, with contact from law enforcement and also from medical personnel, that they were seeing an increase in those presenting for services. And so, what we decided to do was strengthen our partnerships with local hospitals, Grady, for example, so that we could have positive dispositions for survivors who are being discharged from the hospitals. But again, to be clear, the number of calls, because the ability to access, the ability to have a conversation privately with an advocate to access services was reduced. And as people were sheltering in place, the ability to get away, say to a support group or to a friend or a family member, was significantly reduced. And people were really in their homes and not able to get to people who could provide safety or any kind of relief from the violence that they were dealing with in their homes. What we know too is that because the way that services were being delivered, obviously we were thinking about safety for those who are providing the services as well as services for those who need the service, and really trying to balance those things together. The ability to access things like shelter, temporary protective orders really shifted in some ways. And so there was a lot of pressure. There were really fewer places for survivors to be able to go. So, for example, even if you could go to a family member, there was some anxiety around travel. And there was even anxiety around family members about being able to receive families. And the same is true for shelter programs. So often, and our program is included in this, COVID tests were required in advance. We had to come up with additional funding to be able to provide hotel stays because we reduced capacity in the shelter to increase our likelihood of keeping people safe and reduce the risk of COVID-19. So there were lots of challenges around the pandemic, and we're still dealing with a lot of those challenges.
Barbara, I guess for some of our audience members who might not know the work that the Women's Center does, maybe can you give a little brief description of the center and the kind of services that you provide? And kind of following up on what you just said, how has the center had to adapt to the social distancing measures, and how has that affected the kind of services that you've been providing to this population?
Sure. So the Women's Resource Center has been around since 1986. And in that time, we're really concerned with helping those who are surviving domestic violence move from the crisis into safety, into stability. And that's not just safety and stability for their physical selves, but also their emotional selves. So we really try to think about services that are designed to support the whole person and the whole family. And in doing that, we provide a number of services, including a 24-hour crisis line. We have emergency shelter. We also provide legal advocacy, children's programs, supervised visitation and exchange. We offer safety planning, some resettlement assistance. We have transitional housing. Uh, Part of what we're really concerned about, though, is not just getting people to be physically safe, but we also have a lot of community outreach really designed to get at the roots of domestic violence. You know, why is this happening and how can communities respond? Because what we're finding is that there's a lot of stigma associated with surviving domestic violence. It's very painful to admit it, to talk about it. And what we also know too is that um, you know, if domestic violence is an issue in your household, it feels so deeply personal. And there's a lot of shame associated with it. But what we know is that it's not a personal problem. It's a problem that belongs to all of us as a community. And so what we're really concerned with at the Women's Resource Center is thinking about how we can get communities engaged in thinking about what we can do as individuals and what we can do as communities to help survivors be safe, and also to help perpetrators make different choices and manage themselves in a different way so that we can all be safe. We can have safe homes and safe communities. Well, I guess I'll stop there.
Okay, no,
Yeah.
thank you. And I kind of wanted to bring in Dr. Young, and I think there was a recent paper that was published by Evans and all, and I think the author actually might be on this call, that measured differences in domestic violence incident reports using police data in Atlanta, Georgia before and during the COVID-19 pandemic. And I think one of their finding was that domestic violence had increased after the lockdown, especially among Black, Indigenous, and POC communities. So I wanted to know, Dr. Yant, have you seen this disproportional effect in the analysis that you've conducted? And maybe after you respond, Barbara, if you could speak to how you're addressing the specific needs of this community. Over to Dr. Yant.
Sure. So this is, let me maybe unpack your question, Mahal, because there's several pieces of it that are important. First of all, I really appreciated Barbara's comment about decline and hotline calls at the center. And there is some work out there suggesting declines in calls for exactly the reason that Barbara mentioned. So I think the experience of the Resource Center could be more widespread. What's interesting to us, and again, what gets reported in newspapers are the sorts of things that, you know, make news, right? And so the fact that we're seeing increases in hotline calls, increases in police reports, increases in court cases, pretty consistent evidence across types of data, to me is a very compelling pattern about what seems to be going on nationally, keeping in mind the caveats of newspaper reports. That said, we all know that the cases that are reported by the police, the cases that do make it to courts, are really sort of the tip of the iceberg. And so Barbara's comments about the quality of relationships in the home, the kinds of experiences of psychological violence, other forms of violence that may not result in a report, that may not result in a police report, reveals to us that the data that we have available now are typically substantial underreports of women's experiences and children's experiences in the home. So I think, unfortunately, our full understanding of the nature of the strains in the home, in partnerships, is going to take time to document and to document well. There are routine national surveys that we'll be incorporating into our work. The sad thing for me about the kind of work that we do is the story unfolds after the emergency has really been already unfolding. So I think what we're seeing in terms of the data reflect sort of the tip of the iceberg of women's and children's experiences in the home, other diverse relationships in the home, in a really prolonged, acute, multifaceted set of strains on households. So the work that Barbara and the Resource Center are doing are so critical and timely, and my hope is that these kinds of conversations can raise awareness, and then as data continue to unfold, to document the kinds of experiences that Barbara's describing contemporaneously, can be usefully deployed for advocacy and policy.
Yeah, thank you so much for saying that. And if I could just follow up a little bit, you're exactly right in that, and especially because of the pandemic, often survivors are far less likely to call and far more likely, I think, to minimize the abuse in their homes. And I think that's why we saw more reporting with law enforcement and with medical personnel, because when the situation became extreme, then there was that involvement. What was happening in the homes is, you know, because there are so few opportunities, you know, people are losing their income, opportunities for housing just weren't there. Opportunities to connect with friends and family weren't really there. And so there was this really overwhelming tendency to kind of minimize what was happening in the home. You know, I was just shoved, or I was just slapped, or, you know, my access to money to buy food was reduced, or I'm dealing with a lot of emotional abuse. So a lot of that was going on, and it was really, really painful. And I think what we saw eventually when it came when it was more likely that survivors could call, as they were talking about being victim to these really painful, small, and I use that lightly, small kinds of abuse that they were suffering in their homes, that because of the pandemic, they were more likely to just kind of gloss over because access to services was really more limited during the pandemic. Yeah. And I'm so sorry, Maletta, I don't remember your question.
No, you just answered it. Thank you so
Yeah.
much.
Okay.
I want to move on to another really important issue that we wanted to talk about within this context, which is mental health. And the pandemic has triggered a huge mental health crisis, especially among women. And according to a recent UN report, women, especially those between the ages of 18 and 24, have seen their mental health disproportionately affected during this crisis. And I want to start with you, Barbara. Have you seen evidence of this among survivors or family members that you have encountered? And what have been some of the mitigation efforts that your organization has used to address potential worsening mental health among survivors?
Yeah, absolutely. Thank you for the question. I really always appreciate opportunities to talk about mental health. It's just so important because it's not something we talk about often enough. And I think if there's one benefit of the pandemic is that it's really given us permission to talk about what's happening for us on the inside. And yes, we have seen among survivors pretty significant reports around things like anxiety, around depression, and that's attributed to so many factors. Of course, if you don't have a safe place, a safe refuge, that's a pretty big difficulty. And I think for many of us, that's been the thing that we've pointed to because we're dealing with uncertainty around the pandemic. There was a lot of upheaval culturally and politically, the social justice climate. I mean, there are all these pressures that we're all dealing with. And most of us talked about how, being able to be with friends and family, being able to retreat to a safe place in our homes was kind of how we got through. But so for survivors of domestic violence, there is not that respite. There is not that space. So there's no place where you can just kind of let your hair down and say, in this moment, I'm okay, I'm unsafe. Because a lot of the uncertainty that we're dealing with the pandemic, we don't know what's going to come next. Survivors are living with this in their very homes. They don't know what's going to happen from one moment to the next. And so part of what we try to do as a part of this pandemic is, whenever it's safe, is to bring in more opportunities for connection, more opportunities for belonging, and recognizing that access to mental health services is somewhat limited, really reminding survivors about their own inner resolve, their own inner goodness, helping people really connect with their resiliency. And so we're focusing on more things like yoga, on meditation, and we're doing more connections. So I talked about this feeling of belonging. We have a sisters group. The Sisters is Survivors in Service to Extend Resiliency. And this is a group that's pretty active. We talk to each other daily via group text. And we also have regular weekly meetings. So there's a moms meetup that meets on Tuesday via Zoom. There is meditation that meets on Thursdays. There's a sister circle that meets on Saturdays, opportunities to connect with one another. There's yoga that meets on Sundays. And then recently on Saturdays, we have a fitness group. So we do exercise. And then we also have sistership. And it's what you might think of with mentoring, but the idea is that it's mutual. So there are volunteers from the community who pair with survivors in a relationship where they share together about just whatever comes up. And it's an opportunity to be with one person who can really see you and witness your goodness, witness where you're trying to go moment by moment. And I think it's really important, the connections, because that's what human beings really want, to feel like they belong, and that supports our mental and our emotional health.
Thank you, Barbara. And,
Yeah.
and Dr. Young, from your work on GBV, both in Georgia and around the world, what are some of the successful survivor-centered mitigation efforts that you have seen have worked for preventing GBV and maybe worsening mental health among survivors? Are there some specific examples of best practices that you can share with us?
Oh, that is such a great question. And the pandemic has raised a lot of questions about how to provide comprehensive, what we call comprehensive social protection programs in a situation of lockdown in settings where people don't routinely have access to the phone. If they do have access to the phone, whose phone is it? Do they have access to the internet? So a lot of the efforts around online and remote strategies come with, for either data collection or programming, have come with, I think, healthy and robust questions around the ethics of doing this kind of work safely. So as a result of that, there have been a new set of guidelines around how to appropriately reach women, to understand how prevalences, if you will, of experiences are changing over time, if that's feasible to do, and if so, how. But also a lot of creative thinking, not dissimilar to what Barbara has been describing for the Resource Center, about innovative ways to safely provide programming that may not be directly related to violence, but provide the kinds of social, emotional, and even financial support to women who have lost their jobs and who have experienced extended lockdown periods in some settings. So I think some very healthy, robust ethical conversations have taken place about how to reach women in settings that are very remote and don't have routine cell phone access, don't have routine internet access, but then also how to safely leverage some of those technologies in the places where they do exist to provide safe mental health-based services, safe delivery of digital money, for example, as a mechanism to provide financial support to destitute families. My hope from this very difficult period is that there will be novel ways to reach women who historically have been very, very difficult to reach.
Mm-hmm. Yeah, one of the things that's been really helpful for us thinking, and thank you for talking about that, Dr. Young, is how we can connect with women who do need resources immediately. And we've done some things that we've not been able to do or not maybe thought about doing before. So even using Cash App to get money to a person who needs to, get on MARTA if they're getting out, or buy food, sending out gift cards or sending Instacart if that's possible. So really just trying to be able to be creative about getting resources to people who need them immediately, and not, you have to come do an application, you have to come, make it easy as possible for people to get the services that they need.
That's right.
Mm-hmm.
Thank you both so much. I think we have a lot of questions in the Q&A. So but before we go there, I kind of wanted to ask you to give us some examples of, some innovative approaches that might have worked. It doesn't have to be during the pandemic, but in prior years, enriching women, if you wanted to share that with the audience. Do you have some examples of specific or innovative strategies that have worked in terms of reaching women who experience violence?
Go ahead, Barbara.
Yeah, so one of the things that we are really aware of at the Women's Resource Center is that communities are so different. And we really also always want to make sure that we're practicing cultural humility. I noticed that Aparna's on the call from Raksha. We try really hard to partner with lots of different agencies so that we can reach people across all spectrums, across all communities, just recognizing that domestic violence, gender-based violence is not something that happens only in certain communities. And I think even just beginning with that awareness and, having some sense, again, of curiosity and connecting with as many people as possible to keep the conversation going. That way, when we talk about domestic violence, whoever is listening knows I'm talking to you and about you. And so either that means services are available to you, and or there's something that you can do to help ease the problem. Just thinking about what we're doing in terms of innovation, part of that really is about talking to as many people as possible with as much curiosity as possible, and with a sense of always being ready to learn and being able to address whatever the specific concerns are of the person that we're listening to and talking with.
Thank you, Barbara. Go ahead, Dr.
Yeah.
Yan.
Mhm.
So one of the things I'll add, in addition to agreeing fully with Barbara and maybe a complementary piece of this, from a public health standpoint, one of the things that we try to think about is, to what extent are there sort of demonstrated or what we call evidence-based programs that can really have a sustainable and positive, provide sustainable and positive support to survivors of violence. A piece of that I really liked that Barbara mentioned is the importance of cultural specificity and how one thinks about appropriately tailoring and adapting those kinds of programs to preserve those elements that seem to work, while at the same time recognizing the need for local adaptation. So one of the things that our group does with many long-standing relationships, and it takes a lot of time to build those internationally, is to work with local partners who are familiar with the local setting, who understand what's feasible, what's not feasible, to keep, to discard, to adapt. And so the process of adapting evidence-based programming to be attuned to the local needs of survivors is really critical. So we really support thoughtful, comprehensive, tailored adaptations of evidence-based programs to local contexts.
Thank you very much, Dr. Yant. I just want to follow up on that point, because we've had a couple of questions about what are some of the additional barriers for survivors who might have limited English proficiency or immigration concerns, and how this has played out during the pandemic. Kind of either one of you or both of you.
Yeah, I'll actually talk about that. That's actually been an ongoing concern for us at the Women's Resource Center. And one of the things that we always try to focus on is people over programs. And so what that might mean is if we're serving a family where there are not documents in place, they could potentially be with us for a year because it takes time to get these things in place. That might also mean that after that time, when we feel sure that documents are soon forthcoming, that we might work with a community partner to pay the rent for 6 months so that they can kind of start moving before they're able to earn any income. The other piece, again, is, as I mentioned, we work pretty closely with community partners for translation services. And when those aren't available, we work with the language line. And we also have a lot of flexibility in terms of how we do things. Something as simple as providing meals. We ask survivors what they want to eat, and we go to the farmers market and to the international store. We load everybody up on the van that feels safe to go, and people buy what they want because we recognize that food is an immense comfort, and being able to have food that reminds you of home and that gives you a sense of place is so important. And that's part of how we help people feel seen and provide services that feel relevant to individuals.
Thank you, Barbara. Dr.
Yeah.
Yan, anything to add?
Yeah, Mahal, could you repeat the question?
The question was around how we could address communities where there might be a language improficiency, or immigration concerns when seeking services during this pandemic.
Yeah, that's actually, so internationally, that is a huge issue. We're now in the process of interviewing stakeholders in civil society and in government ministries in a number of countries to to address questions about programming to empower, in particular, women and to try to mitigate their risks during the pandemic. And one of the things that has come up repeatedly are the groups in particular countries that are extremely marginalized, often racial and ethnic groups that do not have particular kinds of identity cards. And the result of that is a virtual complete inability to access services for basic needs, including healthcare services, including schooling for their children, including the ability to open up a bank account. And so there are groups, and this is the lack of access to an identity card has come up in multiple contexts. And so just recognizing the extreme vulnerability of these groups and finding ways for grassroots efforts to meet immediate needs, but also at the same time, policy efforts to provide more sustainable protections to these groups. And also trying to identify ways to include them in data collection efforts so their experiences can be more widely documented for the purposes of advocacy. So this is an issue that has come up among stakeholders in civil societies, organizations in particular, in a number of settings around the world, and has been acutely felt during the pandemic.
Thank you very much, Dr. Yant. We have a question here in the Q&A box, and I've been reading it. I think it's a really tough one, so I'm just going to pose it and see what both of you think. And the question is, what kind of advice can you give for situations where victims might be trapped with their abusers in their own residencies and do not have access to a cell phone or a landline and might be in complete control by their abuser? What can outside resources do to reach these women?
Yeah, that is a tough one. And I certainly want to, preface my comments by saying that every situation is different. But just in terms of thinking about some things that a person might do, if somehow you have access to the internet, you might send a message. We do accept messages via our website. You also might, when this person is in the shower or sleeping, try to get the attention of a neighbor, maybe send out a letter or a note to the neighbor to see how you might be able to get connected to services. And then, thinking about how you might make your safety plan. I even heard of a woman who started gathering things together in a trash bag, pretending that she was taking the trash out. And over time, she was able to get, a couple of clothing items, medication, and some things for the children. And then when the moment was right, she was able to get this bag and get away with the bag. If there are opportunities to take a couple of dollars here and there, while this person is sleeping so that you can use that. And then as soon as you're able to get away, our crisis line is available 24 hours a day. So if you can just get out of the house maybe and get to a neighbor, or if you're able to call the police, then you can begin to think about what your next steps can be from there. I mean, there are emergency services available. Absolutely, it's not easy. But I do think that just kind of slowly planning, if you have emergency items, your documents, gather those things together and put them someplace safe so that when you can get away, do that.
Thank you, Barbara.
Yeah.
Dr. Yant, do you have anything to add? Or I can go to another question.
I think those are great suggestions.
Okay. We have a question here around how these issues, that is GBV, might particularly impact pregnant women in small towns in rural Georgia, especially in counties without sufficient women's clinic and OBGYN care. Do you have any thoughts on that?
Yeah, that's you know, I know that doctors' offices are really important places for women to be able to talk about experiencing domestic violence. And so I'm really hoping that conversations like these really raise the awareness among doctors about being able to access services for survivors. And so I think I mentioned earlier that we have a relationship with Grady so that if there's an issue of domestic violence, social workers or doctors from there will call us. And I'm thinking that that's true in many hospitals. So for people who are working in those areas, it's really important to have more community outreach and education with the staff there so that they know how to respond if they're presented with a survivor. And even if the conversation does not come up, I think it's important that they're trained to ask because they might not know that services are available and to make sure that they have access to numbers so that if they need services, they know who to reach out to and what they can expect when they call.
Thank
Yeah.
you. Yeah, go ahead, Dr. Yan.
Well, the reason why this is such an important question, and one of the things I'll underscore in this conversation, are the cascading impacts of maternal exposure to violence. So just to underscore for the group here, in addition to the immediate physical, psychological, economic impacts of violence on women, these sorts of experiences disrupt access to prenatal care. They disrupt potentially the ability to effectively get delivery care. They can disrupt a woman's capacity to effectively breastfeed her child. They can disrupt the transition to complementary feeding. They can disrupt the ability for women to access healthcare for their own infants and young children. And all of this can have cascading impacts on the long-term opportunities and trajectories of children. So all of these touch points also are points of potential intervention if healthcare providers of diverse backgrounds have raised awareness about potential exposures and do a good job of person-centered care and identifying women who are potentially at risk. So being aware of the potential touch points by understanding the impacts on access to various services, I think is an important potential lens for a strategic approach to identifying women in need.
Thank you very much, Dr. Yan. There are some specific questions to Barbara. I'll just try to combine them. The question is, Barbara, how do you incorporate mindfulness in your work and programs? And how can undergraduate students who are really interested in getting involved at the Women's Center get involved?
Sure. We do it in lots of ways. One really basic way is at the beginning of every meeting, we take a moment just to settle into this space, to land in our bodies and really be aware, to be conscious of the fact that we deserve to be seen and cared for. And that in this exchange, that whatever I say is not going to be something that's held against me, that I'm not going to be shamed or blamed, that I can bring forth whatever is inside, and it can be witnessed in a way that's compassionate and also offers the reminder to be self-compassionate. And then we also, as I mentioned earlier, practice regular meditation. We also practice something called tracking. You know, we invite survivors and we also remind ourselves about the value of noticing what's happening inside of our bodies moment to moment. Because when we can be with what's happening, then we can know how to care for ourselves, how to respond to ourselves. And we can also be reminded that we all experience a range of feelings day to day, moment to moment, and that these feelings come and go. And I think what's important about this is that for a lot of us, if the feelings we experience are unpleasant or uncomfortable, we feel fear and aversion. And we want to be able to let survivors know that they can be with whatever comes up in a way that's skillful and with courage. And so that's how our mindfulness practice works. And then in terms of how volunteers might help, we are so grateful for volunteers. They've been so wonderful for us during the pandemic, especially with data entry, with sistership, with leading groups. We even have some students now who do Zoom story time and games with children. So they might do a scavenger hunt with a 3 or a 4-year-old on a Saturday morning, or they might play Simon Says with a 5-year-old, or they might read to a teenager, or just pal around. It's just really, I think I mentioned this before, that it's so important to feel like you are seen and you belong and you are connected. And so these partnerships have been so important.
Thank you both so much. Before we pass it on to our communications lead, who's going to be sharing some resources around GBV in Georgia, I wanted to give you both an opportunity for any final comments or thoughts. Dr. Yan, we'll start with you.
Let me just say that it's wonderful to be here with Barbara. I've known the Resource Center for years, and the work that they do is just incredible. I really appreciated Barbara's emphasis on mindfulness and developing the skills around mindfulness, really as a lifelong strategy for survivors of violence. I also appreciated the emphasis of this chapter on understanding gender-based violence in the context of COVID and outside the context of COVID. And I'm very grateful for the opportunity to raise awareness about the experiences of a very large percentage of our population in the United States and elsewhere. So the more that we can have these kinds of conversations, I think the more attuned people will be for the needs of survivors.
Yeah. Thank you so much, Dr. Yount. I really appreciate that. And the Women's Resource Center, our goal really is to not have to be here anymore. I think that's probably everybody's goal. We really want all people to feel safe. We want all people to feel valued. And awareness is a really big piece of that. So I'm also grateful that we're having this conversation. And I'm also hopeful that this will inspire more people to think about how they might move the dial around domestic violence. I think we often think about it's the responsibility of, agencies or researchers, but we know that so many things contribute to the problem of domestic violence. And there are things that we can do in our daily lives because we are all learning from each other. So we have to be careful about our language, about our values, even about the way that we use power in our own lives. We really have to examine what we are doing and how we can shift some of those attitudes and some of those behaviors, because it really does make a difference. So in helping us uproot some of the problems. So I think I would just leave with that. Think about where your sphere of impact is and use it.
Thank you both so much for joining us today and sharing your experiences. It's been a pleasure to learn from you. I will now pass it on to Andy Tucker, who's our communications lead, who will be sharing some resources around addressing GBV in Georgia. Over to you, Andy.
Thanks. So my name is Andy Tucker. I'm the communications lead for Women in Global Health Georgia. And first, let me just thank our speakers for today. I know that I've learned a lot from this conversation, and I'm so glad that you were able to be with us to share those valuable perspectives. So thank you. So after I've had a conversation like this, where I've learned something about an issue, I often like to have an opportunity to respond, to be able to do something with this information that I've gained, and to respond to an issue that I'm passionate about. So today I'm going to share with you some action steps that the Georgians that are attending our webinar can take to protect the safety of girls and women here at home in the state of Georgia. So the Georgian legislative session is currently underway, and there are 4 pieces of legislation that I'd like to highlight for you today that have been proposed in this legislative session that will protect women and girls in the state of Georgia from violence. So I'm going to share those 4 bills with you now. The first of which is Senate Bill 75, SB 75, which is called the Lease Release Bill. So we know that 312,000 Georgians are stalked each year, and that 76% of women that are killed by their intimate partner were stalked in the year preceding their death. So we know that stalking is a really serious issue. And this bill would allow victims of stalking to break their lease without financial penalty. So to be able to move away from a threatening situation. The second bill that I'd like to share with you is HB 458. Sexual misconduct training. And under this piece of proposed legislation, the Georgia Composite Medical Board would require certain training related to sexual misconduct for members. So this would require refusal of license, certificate, or permit to anyone who pleaded guilty or was found guilty of committing sexual assault on a patient in the state of Georgia. And all newly appointed board members would be required to participate in sexual assault training and education. The third bill is HB 255, which is the Sexual Assault Reform Act of 2021. And this bill would create an online rape kit tracking system, which would allow survivors to monitor the status of their rape kit. So they have the ability to log into a website to see where the kit is, what's happened to it, if it's been tested, and if it has been tested, if it matches potential suspects. So moving forward, justice for those that have been victims of rape. And then the final bill that I'd like to share with you is 231, which is called Closing the Gap. And the goal of this bill is to close the dating violence gap by expanding domestic violence protective orders to cover dating relationships. So Barbara mentioned temporary protective orders while she was talking about services that survivors have had challenge accessing during the pandemic. And currently in the state of Georgia, victims of abuse who are not married to, don't live with, or do not have a child with their abuser are unable to obtain a family violence temporary protective order. Georgia is only one of 3 states that don't offer this protection, and this can deny access to potentially life-saving relief for some of the most at-risk victims of relationship violence, including folks who are pregnant, teens, and young adults in dating relationships. So all 4 of these pieces of legislation have the opportunity to protect women and girls in the state of Georgia. So then the question is, how do you go about supporting these pieces of legislation? So there's a website called openstates.org where you can find the name and contact information for your state legislators. And I want to encourage you to reach out to them by phone or by email. Phone is preferable. If a state legislator gets 10 phone calls, that's a big deal. So we have about 60 people on this webinar. So I want to encourage you to reach out and to first tell them that you're a constituent. It's important that they know that they represent you. Let them know that you really care about the safety of women and girls in the state of Georgia, that that's important to you. And finally, let them know that you support these pieces of legislation and that they should as well. So that's it. It's just those 3 parts. And I've posted all of this information on our Twitter page with information about each one of the bills that I talked about, the name of the bill, and then a link to the openstates.org website where you can find your legislator and contact information for them to follow up. So now I'm going to pass it over to Lauren, who's going to give us a preview of our next Women in Global Health Georgia event.
Yeah, thank you, Andy. Hi, I'm Lauren Abrams, and I'm going to tell you about some things that we have coming up that we hope you'll be engaged with. In honor of Women's History Month, the Task Force for Global Health's Council for Opportunity, Diversity, and Equity, or CODE, along with Women in Global Health Georgia and the Georgia Global Health Alliance are holding a virtual panel event called The Faces of Global Health, Women in Leadership. This facilitated panel discussion will focus on the experiences of women in leadership in the field of public health. And Andy Tucker, who you just heard from, is going to moderate the event. It'll take place virtually on Tuesday, March 23rd at 1 p.m. Eastern Time. The event's open to the community as a way to amplify the stories of women in global health, and we hope that you can join us. Women in Global Health Georgia is also planning an event in early summer featuring a conversation on global health policy and public affairs among women leaders, and the event will be moderated by Paige Alexander, the president and CEO of the Carter Center. I also want to let you all know that in the fall of this year, we're going to launch our mentorship program, so stay tuned for more information about that. We'll be communicating more about how you can be involved with that in the summer. And lastly, I just want to say thank you to everyone for joining today. I hope to see you at these future events and that you'll stay involved with Women in Global Health Georgia. Thanks.